Hi, I'm Julia Raifman. I'm an assistant professor here at the Boston University School of Public Health. I conduct research on policy drivers of health inequities, including those that affect LGBT populations. I'm looking forward to sharing some of my research with you today in this presentation on how we shape the social environment, improving LGBT health equity. There are three main points that I hope you'll take away from today's presentation. The first is that being LGBT is increasingly common, and we are all likely to work with LGBT people. The second is that LGBT people are affected by a number of health inequities. And the third is that how we shape the social environment affects LGBT health. So as we get started, let's define what we mean by LGBT. LGBT refers to the concepts of sexual orientation and gender identity. Sexual orientation has three dimensions: attraction, sexual behavior, and identity. And on each of those dimensions, someone can be straight, or lesbian, gay, or bisexual, which I'll refer to as LGB throughout this presentation. Gender identity refers to the relationship between gender identity and sex at birth. So someone is transgender if they identify as a gender that is different than their sex at birth. And someone is cisgender if they identify as a gender that corresponds with their sex at birth. Sexual orientation and gender identity are distinct concepts, so that one can be both transgender and straight, or transgender and gay. So how many people in the United States are LGBT? About 3 to 3.5% of men and women report that they are gay, lesbian, or bisexual, and an estimated 0.4% of the adult population is transgender. You might have a sense that more adolescents report being LGBT, and that's correct. About 8% of adolescents report being gay, lesbian, or bisexual, and another 3% report being not sure of their sexual orientation, so that a total of 11% of adolescents are considered sexual minorities. An estimated 0.7% of adolescents are transgender. And we don't know how this will change over time for this new generation, because we've just started to collect data on sexual orientation and gender identity. So we'll have to see what happens as we collect those data into the future. So the first takeaway is that being LGBT is increasingly common, and we are all likely to work with LGBT people. Unfortunately, LGBT populations experience a number of health inequities. Mental health is one of the main health inequities that affects LGBT people. So here in this graph, we have sexual orientation on the x-axis, with heterosexual people on the left and gay, lesbian, and bisexual people on the right, and males depicted in gray and females depicted in red. Then on the y-axis, we have the percent who report one or more suicide attempts in the past 12 months. And unfortunately, what the data show is that LGBT adolescents are about 5 times more likely to report a suicide attempt in the past 12 months relative to their heterosexual peers. We see similar disparities among LGBT adults, though those are of a lesser magnitude. The other main health disparity that affects LGBT populations is HIV. So unfortunately, in the United States, 18% of men who have sex with men have HIV. And men who have sex with men are 80 times more likely to acquire HIV in their lifetimes relative to men who have sex with women. Here on the right, we have a graph that depicts on the x-axis the time in years, and on the y-axis the estimated number of new diagnoses. And what you can see is that top line on the right is men who have sex with men. And even though men who have sex with men make up a small proportion of the population, they have the highest number of estimated new diagnoses of HIV, and their numbers of new diagnoses are increasing over time only in this population. There are a number of other health disparities that also affect LGBT populations. Those include depression, anxiety, substance abuse, violence victimization, cancer screening, and disparities in other areas of health as well. So that brings us to our second takeaway, which is that LGBT individuals are affected by a number of health inequities. These health inequities are not inevitable, and they occur in a context of unequal rights and stigma. In the next section, I'll present 2 studies on LGBT rights and health. There have been a number of changes to LGBT rights in recent years. In 2015, the Supreme Court made same-sex marriage legal throughout the country. But since then, we've seen a number of changes in other states. So in Kentucky, schools can bar LGBT students from student groups. In Mississippi, businesses have broad license to turn away LGBT customers. And in Tennessee, healthcare providers can specifically turn away LGBT patients. Then earlier this year, the Supreme Court also left unclear in the Masterpiece Cake Shop ruling whether states can prevent discrimination against LGBT people. So how do these policies affect health? Much of my research is based on fundamental cause theory, which suggests that structural stigma, defined as the societal level conditions, cultural norms, and institutional policies and practices that constrain opportunities, resources, and well-being, lead to stigma at lower level institutions such as in schools and in hospitals, to familial stigma, to peer stigma, and to internalized stigma. And that this in turn leads to health disparities across domains of health, across time, and across place. And the studies that I present today will focus on institutional policies as a particular form of structural stigma that leads to health disparities. There is prior evidence that stigma is associated with LGBT health disparities at the state level, at neighborhood levels, at familial levels, at the peer level, and at the internalized stigma level. What we can't tell from studies of association like these is whether stigma causes worse health, because it's possible that some other factor drives both stigma and worse health. So with this study on state same-sex marriage policies and adolescent suicide attempts, we tried to take the next step in terms of investigating whether policies that stigmatize LGBT populations cause health disparities. And I'm very grateful to my co-authors for their many contributions to this work. So as the background, I'm just returning to that slide that we saw before on suicide attempts in the past 12 months. And the fact that LGBT adolescents are about 5 times more likely to report a suicide attempt in the past 12 months. Unfortunately, suicide is a reality for LGBT youth, and for all youth. It's the second leading cause of fatalities among those aged 15 to 24 in the United States. There is prior evidence on sexual minority rights and health. In Massachusetts, same-sex marriage was associated with reduced mental health expenditures among men who have sex with men. And same-sex marriage bans in 16 states in 2006 were associated with increased psychiatric disorders. The objectives of this study were first to estimate the relationship between state same-sex marriage policies and all adolescent suicide attempts, and secondly, to assess whether changes in suicide attempts were concentrated among sexual minority adolescents. Moving on to the methods that we used in our study, we used data from the Youth Risk Behavioral Surveillance Survey from 1999 to 2015. The Centers for Disease Control and Prevention collect these data, which are representative for all of the 47 states that collect the data. There were 32 states that passed same-sex marriage policies prior to January 2015, and 15 comparison states that did not pass same-sex marriage policies by January 2015. We looked at the sample of all students, as well as those students who reported being LGB in the states that collected data on sexual orientation. This is a timeline of state same-sex marriage policies. So you can see that Massachusetts was the first state to pass same-sex marriage in 2004, and the number of other states began passing same-sex marriage policies in 2008 and 2009, with a big increase in 2013 and 2014. The data that we used for this study were only collected every other year in the years highlighted in bold, and so we considered states to have passed same-sex marriage if same-sex marriage was implemented for the full time period of data collection in each year. We dichotomized the data here for the purpose of the figures that we'll present. So we consider states that passed same-sex marriage prior to 2012 to be Wave 1 same-sex marriage states, and those that passed same-sex marriage after 2013 to be Wave 2 same-sex marriage states. Okay, so this is the analytical approach that we took to this study. So this is easiest to describe in a figure, and I'll take some time to really make sure that we describe it in detail, because it's the method that I used in both of the studies I'll present today. So on the x-axis we have time, and we have a pre-period and a post-period. On the y-axis we have the outcome, in this case suicide attempts. Here we have policy change states in red and then comparison states in blue. And the idea is to compare the pre-period and post-period data in the policy change states and in the comparison states. If the states have the same time trend in the outcome in the pre-period as these states do, then we could expect them to have the same time trends in the post-period if there hadn't been a policy change. So the comparison states allow us to see what happens with no policy change. Then if we have a policy change only in those red states, and we see that there's some difference in the outcome in the post-period, then we can attribute it to the policy change as long as we meet those two assumptions. The two assumptions are, first, that we have parallel trends in the outcome in the pre-period, in the comparison states, and in the policy change states. And secondly, that we don't have anything else going on at the same time as the policy change that might affect the outcome only in those policy change states. And in this study, we had a really a nice opportunity to do a really rigorous evaluation, because different states passed same-sex marriage policies in different years, and it was unlikely that there was some other policy change or other change in the social context that happened with the same kind of timeline as same-sex marriage. An additional step that we take when we look specifically at comparing LGBT populations is to do a difference in differences analysis. And this sounds complicated, but all that it involves is adding an additional control group. So we look specifically at those who are LGB in the policy change states and LGB in comparison states. And this lets us see, is there something broad going on that is generally affecting LGBT people across states, or is it really only something that's affecting LGBT people in policy change states? And similarly, with the additional comparison group, we add those who are straight in policy change states. And so we can see, is there something going on that is broadly affecting all people in policy change states, or is it really that the policy that is likely to affect LGBT people is only affecting those who are LGB in policy change states? Okay, so moving on to describing this analysis in further detail, difference in differences methods can be implemented as regression analyses, and that's what we did in these studies. So the main outcome in our regression analysis was the outcome of one or more suicide attempts in the past 12 months. The main exposure variable was state same-sex marriage policies. The control variables that we included were individual age, sex, race, and ethnicity. We also controlled for state unemployment and state LGBT non-discrimination policies. We controlled for year, and importantly, we controlled for state, which here has the effect of controlling for all baseline differences in state suicide attempts, so that we're only focusing on changes in suicide attempts associated with the policies rather than differences in underlying suicide attempts, which could be due to many factors. It also has the effect of controlling for all characteristics of the states that don't change over time. So we know that the states across the United States differ from each other in many respects, and so those things that we think are relatively stable about the states, such as cultural differences or political differences, this analysis controls for all of those time invariant characteristics. So moving on to our findings. This is just a description of the sample and to show you that the population in the same-sex marriage states was relatively similar to that in the non-same-sex marriage states, with the main difference being that there were a few more people who were white and of other race in the same-sex marriage states and a few more people who were Hispanic and African American in the non-same-sex marriage states. And we did control for these factors. Okay, so this is that important slide that shows you whether or not there were parallel trends prior to any policy change. So here on the x-axis, we have time in years, and on the y-axis, we have the proportion of adolescents who reported a suicide attempt in the past 12 months. And you can see that in the gray states, which are the non-same-sex marriage states, and in the red and blue states, which are the wave 1 and 2 same-sex marriage states, that across all of those different groups of states, time trends are pretty flat, that there is really little change in suicide attempts over time. This is the main effect slide. So this is an important slide to focus on and to see what happened when states passed same-sex marriage policies. So here we've changed the x-axis. It's now time in years again, but we've shifted the axis to depict years before and after same-sex marriage policies. So you can see in that pre-period, those relatively parallel trends over time, pretty unchanging trends. And then after states passed same-sex marriage policies, with the Wave 1 states depicted in blue and the Wave 2 states depicted in red, then there was a decline in suicide attempts. And this graph depicts all adolescents. So we can actually pick up this effect when we look at the full population of adolescents in each state. When we ran our regression analysis, these were our main results. So here on the left, we have baseline suicide attempts prior to marriage equality policies. So among all students, 8.6% of students reported attempting suicide prior to same-sex marriage, and 28.5% of sexual minority students reported attempting suicide prior to same-sex marriage policies. Once states passed same-sex marriage policies, we saw a decline of 0.6 percentage points among all students, which is equivalent to a 7% relative decline. We saw a decline of 4 percentage points among sexual minority students, which is equivalent to a 14% relative decline. And this is equivalent to 134,446 fewer adolescents attempting suicide each year if the estimates applied to all 15 to 19-year-olds in the United States. So to summarize these findings, same-sex marriage was associated with a 7% decline in the proportion of adolescents attempting suicide in the past 12 months. This is actually a really large reduction in suicide attempts relative to the Healthy People 2020 goal, which was to reduce adolescent suicide attempts by 10%. And the relationship between state same-sex marriage policies and adolescent suicide attempts was concentrated among sexual minority adolescents. Fortunately, these results were able to inform real policy change. So there were a number of countries that were considering policy changes to same-sex marriage at the time that the study was published, although the United States had already passed same-sex marriage by the time the study was published. So in Australia, researchers used this study to estimate that 3,000 teen suicide attempts would be prevented each year if Australia passed same-sex marriage. Unfortunately, Australia did go on to pass same-sex marriage. Are there any questions about this study before I move on to the next study? Okay, so I see we have one question, which is, why does this study only mention LGBT people, and what about transgender people? This is an excellent question, and I definitely think it's important that we begin to have studies on how similar policies affect transgender populations. Up until now, we've been really limited in what we've been able to study for transgender populations because the data have not been collected. The big population surveys have not asked questions about gender identity, but the behavioral risk factor surveillance system data started including questions on gender identity in 2014. So as we have more data over time, it will be possible to do similar studies looking at how policies affect transgender health. Similarly, as researchers develop methods of assessing who may be transgender using things like claims data, it may be possible to see how policies that affect transgender populations affect transgender health. I think an important point here is to highlight how critical it is that population surveys include those questions. All right, thank you. With that, I'll move on to the next study. So the next study is on state policies permitting the denial of services to same-sex couples and LGBT adult mental distress. I am again very grateful to my co-authors for their many contributions to this study. We are at a turning point in terms of institutional policies that affect LGBT populations. So as I mentioned previously, there are these policies that permit the denial of services to LGBT people across school groups, healthcare, and businesses. So it's important for us to understand how these policies affect LGBT health. This study focuses on adults who experience mental health disparities that are similar to those of adolescents, but of a lesser magnitude. So this graph depicts sexual orientation on the x-axis, and again we have heterosexual populations on the left and gay or lesbian or bisexual populations on the right. We have males in gray and females in red. And on the y-axis we have the percent with severe psychological distress. And severe psychological distress is about 1.75 times more common among LGBT adults relative to heterosexual people. So the objective of this study was to estimate the relationship between state laws permitting the denial of services to same-sex couples and changes in LGBT adult mental distress. The methods that we used for this study were to use data from the Behavioral Risk Factor Surveillance System, which are representative of adults in each state. The BRFSS data are essentially the adult equivalent of the YRBS data that we used for the prior study. We used data from adults aged 18 to 65, and in states that collected LGBT data between 2014 and 2016. Those states that collected LGBT data during this time period are depicted in green on this map. The exposure of interest was one or more laws denying services to same-sex couples and implemented in the prior calendar year. There were 3 states that passed such policies and that had collected data on sexual orientation. The first state was Utah, which in 2015 passed a bill permitting same-sex marriage license refusal. The second state was Michigan, which in 2015 passed bills permitting same-sex adoption and foster refusal. And the third was North Carolina, which in 2015 passed a same-sex marriage license refusal bill, and then in 2016 passed the famous HB 2, which prohibited state and local LGBT non-discrimination laws. So this is that same map that I showed you before that depicts the states that collected sexual orientation data. Now the states that had policy changes to permit denial of services to LGBT people are depicted in orange, and the control states that we selected for each of those policy change states are depicted in blue. And when states had multiple adjacent states that could be comparison groups, we compared the demographic characteristics of those neighboring states to select those with the most similar demographic characteristics. The main outcome of interest was mental distress, which was measured through the following question. Now, thinking about your mental health, which includes stress, depression, and problems with emotions, for how many days during the past 30 days was your mental health not good? With the response option between 0 and 30 days. The 2-week retest reliability of this question is high at 0.7 for those under the age of 65, which is the population we included in this study. This question has high construct validity for depression and high concurrent validity with more commonly used depression measures, such as the short form 36 and the Patient Health Questionnaire Depression Scale. Now, we dichotomized this main outcome into mental distress on 14 or more of the past 30 days, which is the typical approach that is used to track population health and on which there is prior evidence of LGBT disparities. So again, we use that difference in differences approach. We compared those who were LGBT in policy change states to those who were LGBT in comparison states and to those who were straight in the policy change states. So the idea is that any changes that we saw among people who were LGBT in policy change states should be attributable to the LGBT policy change, which in this case was the denial of services to same-sex couples. And if we didn't see any changes among LGBT people in comparison states, and then that would rule out that there was something broadly going on affecting all LGBT people. And if we didn't see changes among people who are straight in policy change states, then that would rule out that there was something broadly going on affecting the mental distress of all people in the policy change states. So again, we can conduct this analysis as a regression analysis, and the outcome of interest was 14 or more days of mental distress in the past 30 days. The main exposure variable was an indicator for being LGBT in a state after that state had passed a same-sex service denial policy. We included a number of control variables, which included individual age, sex, race, ethnicity, and this time we also had income, employment status, marital status, and educational attainment data. We are also able to control for state unemployment and state same-sex marriage policies. We controlled for each year, and we again controlled for state so that we addressed all baseline differences in mental distress by state and only focused on changes in mental distress within each population within each state. And we also controlled for all state characteristics that did not change over time. And I won't go into detail on this, but because we were doing a difference in differences analysis with a small number of groups, we conducted a permutation analysis to estimate our p-value very precisely. So moving on to our results, our sample characteristics. Here we again see that the populations in the control states and in the same-sex denial states were relatively similar to one another. Now this is again that parallel trends assumption. Here on the x-axis we have time in years, and on the y-axis we have the percent with mental distress. And unfortunately the BRFSS data that we used only started including sexual orientation questions broadly in 2014. So prior to 2014 we could only look at the full population without knowing who was LGBT and who was straight. And so what we looked for was whether there were parallel trends in the comparison states and in the policy change states. And here you can see that the trends prior to the policy change are extremely similar to one another. This is our main effect estimate. So here on the x-axis we have time in years again, now 2014 to 2016, with all of the policy changes occurring in 2015. On the y-axis we have the percent with mental distress. And what you can see is in those three comparison groups, you see similar trends that are pretty straight in terms of no change in mental distress over time. So those comparison groups are people who are straight in the policy change states and people who are straight in the comparison states. Those are down below. And then we can see that LGBT individuals have elevated mental distress, but in the comparison states, that mental distress is relatively unchanged over time. In contrast, you can see that in that top red line, people who are LGBT in the states that created same-sex denial policies had really large increases in mental distress. And when we estimated this as a regression analysis, and we controlled for all those covariates, we found that here over on the right, the difference in differences estimates, that 10.13 percentage point increase was really large and statistically significant increase. And what that looks like, these are the same numbers that you just saw presented graphically, but you can see there was about a 1 percentage point increase in mental distress in all of the comparison groups. But among LGBT adults living in states that passed these policies, there was an 11 percentage point increase in mental distress. So the final estimate, the 10 percentage point increase in mental distress, is a 46% relative increase in mental distress, which is really large for these populations. We would be thrilled with any kind of intervention that reduced mental distress by 46%, and this is a really serious increase in mental distress associated with policies that permit the denial of services to same-sex couples. So moving on to the discussion. State laws permitting the denial of services to same-sex couples were associated with a 10 percentage point or a 46% relative increase in LGBT adult mental distress. This is consistent with prior evidence on the relationship between LGBT rights and health, and policymakers and courts should consider potential harm to LGBT mental health. So this study, I think, has a lot of potential to inform policy change. The Supreme Court decision and the Masterpiece Cake Shop decision was released just after this study came out. And so there wasn't time for this study to inform that case. But I think we will see similar cases come up again in the future. And potentially even the Masterpiece Cake Shop case could end up back in the Supreme Court. The Masterpiece Cake Shop decision, as you can see, the subtext on that headline says the ruling is very limited in its scope. And so it sort of leaves unclear whether states are permitted to protect LGBT populations from discrimination and whether states are permitted to discriminate against LGBT populations. So as cases move forward in Mississippi, where there's a man who is challenging a business that denied him cremation services for his husband. In Kentucky, where students have been barred from school groups, hopefully this analysis can support those court cases and provide evidence indicating that policies that permit LGBT service denials are harmful to mental health. And here I've included a tweet that I found really helpful, and I think that really captures the point of this study. Camilla Nord says, "I've never been so bothered by gay wedding cake disputes, but this paper shows that the denial of services to same-sex couples, which are allowed in 12 states, is associated with a 46% increase in sexual and minority adults experiencing mental distress." And I think what she captures well here is that it's not that these policies are not about whether someone joins a different student group or goes to a different doctor or goes to a different cake baker. It's the idea that policies that treat LGBT people as unequal and as deserving of denial of services really affect LGBT mental health. And here I've included my Twitter handle, Julia Raifman. This study has gotten a lot less press relative to the same-sex marriage study, but I think is perhaps even more important in the current context where we see more and more of these kinds of LGBT service denial policies showing up at the state level and now being proposed at the federal level. And so this study is pinned at the top of my profile if you're interested in looking at the study or sharing it. So just to discuss the strengths of both studies have strengths in that they used representative data and that the difference in differences approach is a really rigorous approach to policy analysis that accounts for different baseline levels of mental distress or of suicide attempts by state, and that accounts for time invariant state characteristics. Furthermore, in the policy analysis with the small number of groups, with the small number of states that had passed LGBT service denial policies, we were really precise about estimating a p-value based on the data. There are also limitations to this study. So sexual orientation data were not collected before 2014 in this most recent study, and sexual orientation data weren't collected in all states in the same-sex marriage study. The data may not be generalizable to the whole United States, and we could not control for unobserved state characteristics that also changed over time. But in both studies, we found no evidence of changes in heterosexual mental distress or suicide, suggesting it's unlikely that something else was going on that broadly affected state populations and their mental health. So in conclusion, same-sex marriage was associated with a 7% decline in the proportion of adolescents attempting suicide in the past 12 months. State policies permitting the denial of services to same-sex couples were associated with a 46% increase in mental distress. And sexual minority rights may affect health even in populations that will not be directly affected by rights. So with both of these studies, we see that that's true. So in the adolescent population, we saw a decline in suicide attempts, even though adolescents are unlikely to be getting married. So that suggests that just having marriage rights is important for LGBT people, even if they won't directly benefit from them. Similarly, in the LGBT service denial case, the first policies we saw show up in the LGBT service denial category were same-sex couple service denials. And we looked at people who were part of same-sex couples and people who weren't part of same-sex couples, and found that the effects on LGBT people were the same regardless of whether they were part of a same-sex couple. So that suggests that LGBT service denial policies are broadly harmful to LGBT people, whether or not they will be directly affected by those rights. Unfortunately, there are a number of stigmatizing policies that have been proposed at the federal level right now that are likely to harm LGBT health. So up top we have the Religious Freedom Division, which has been proposed in the Department of Health and Human Services, which would broadly permit healthcare providers to turn away LGBT patients across the country. Then on the bottom left, we have the new Religious Exemption Directive for contractors for the federal government, which would permit people to be fired based on being LGBT. And then over on the right, we have the transgender military ban. And what we see is that LGBT rights really affect mental health quite a bit. And so these policies that reduce LGBT rights are likely to harm LGBT health. So the takeaways that we've had so far are that being LGBT is increasingly common, and we are all likely to work with LGBT people. Secondly, the LGBT people are affected by a number of health inequities, and now these studies show that how we shape the social environment has major effects on LGBT health. Are there any questions before we move on to the next section? Okay, so I see one question. Somebody asked, I want to do this with my research too. Where do I start? So I think it depends what you would like to do in your research, but I think if you're interested in LGBT health disparities, then it's a great opportunity to now have sexual orientation and gender identity data included in some of the large population health surveys. So I would look to the Youth Risk Behavioral Surveillance data if you're interested in adolescents, or to the Behavioral Risk Factor Surveillance Survey data if you're interested in adults, and start to look for where you see those really large disparities and what policies you think might drive those disparities. If you're interested in using differences in differences methods to study other health inequities, I would recommend thinking about what policies you think are most impactful for those health inequities, and starting to look at time trends in those health inequities in before and after states pass those policies. Okay, so if there are no other questions, are there any further questions before we move on? Okay, I see one other question. How is the data used and communicated to support a broad change like same-sex marriage in Australia? So the way that researchers there used the data primarily it was to team up with a group of 5 mental health care organizations and to estimate what a 7% reduction in adolescent suicide would look like in Australia. And they estimated that a 7% decline in suicide would mean 3,000 fewer teen deaths each year in Australia. There were also others who used the data to inform op-eds and editorials, and who wrote about how these data should inform policy in Australia. And similarly, here in the United States, I teamed up with our Dean Galea, as well as with Michael Ulrich, a lawyer in our department, to write editorials about how our findings that same-sex denial policies really harm LGBT health. And I wrote about that and the implications of the Masterpiece Cake Shop Supreme Court decision for LGBT health. Okay, so if there are no further questions, then I'll move on to improving LGBT health. What these studies show us is that shaping the social environment is really important for driving LGBT health. And there are things that we can do to shape the social environment at multiple levels. So at the state level, there are a number of approaches to reducing structural stigma. So the first is supporting policies and policymakers who support equal rights to marriage licenses, to adoption and foster rights, to housing and non-discrimination policies and employment non-discrimination policies, which unfortunately only about half of states currently protect LGBT populations from housing and employment discrimination. Finally, it's important to support policymakers and policies that support transgender non-discrimination, including for restrooms. And here on the right, I've included a story from the Boston Globe that transgender rights could be the closest vote in Massachusetts this fall. So people who live in Massachusetts this fall will be voting on whether to maintain a policy of non-discrimination, including in restrooms for transgender people. And so it will be a very important time to vote on transgender rights directly. There are also structural approaches to reducing stigma that we can take in schools. So LGBT inclusive education across the educational curriculum is important. I've also done research specifically on LGBT inclusive sex education. I found that young men who have sex with men were actually less likely to report HIV education in school, even though they're far more likely to get HIV. If you remember from the beginning, men who have sex with men have about 80 times the lifetime risk of HIV relative to men who have sex with women. So it's particularly important that young gay and bi men learn about how to protect themselves. But what we found is that they're really not. We also found that when young MSM learn about how to protect themselves and they do get HIV education in school, that it is particularly impactful for reducing their sexual risk behaviors. There are also anti-bullying policies that enumerate LGBT protections in some states, and there is prior research by Mark Katzenbuehler which shows that anti-bullying policies that do enumerate LGBT protections are associated with better LGBT youth health. And then similarly, there's evidence that gay-straight alliances in schools are associated with better LGBT health. Finally, I'll end with this study on reducing structural stigma in primary care. This was a study I conducted interviewing 12 primary care providers and 14 LGBT patients about how to improve adolescent health care in the primary care setting. So there were 4 key findings. The first is that there's a first LGBT or T patient for every provider. The second is that assuming heterosexuality can prevent patients from sharing. The third is that signals of support help patients come out to providers. And the fourth is that caring for LGBT patients is rewarding. So point number 1 is that there's a first LGBT or T patient for every provider. So this provider, I asked, how did you go about learning how to care for a transgender patient when they had their first transgender patient? The participant says, I read. I was honest with the patient and his mother, and I was like, I don't know much about this. And they were like, oh, this is exciting. You can learn. Mom's like, I don't know much about it either, but I'm learning. It was a great learning experience and really rewarding to care for the patient. So this just suggests that each provider has a first LGBT or T patient, and not to be intimidated just because you've never had an LGBT patient previously. The second is that assuming heterosexuality can be harmful. This is a lesbian female adolescent who said she'd never ask me if I was with a girl. She'd be like, oh, so do you have any boyfriends? I don't say anything because what am I supposed to say? This was in discussing how her primary care provider asked her about her sexual behavior. And so this young woman didn't disclose her sexual behavior because she didn't feel that her primary care provider was open to it. A way to ask adolescents about their sexual behavior, and all patients, is to say, are you interested in men, women, or both? Keep in mind that this may change over time, and it may also differ for different aspects of sexual orientation. So someone may not say that they're attracted to men, women, or both, but they may say that it turns out they have sexual behavior with men, women, or both. And among individual patients, this can change over time. So not just at a population level, but it may be that someone who's previously only been sexually active with one sex may be sexually active with another sex in the future. Finally, thirdly, signals of support help patients come out to providers. So this patient says, I was apprehensive to tell doctors about my sexual orientation because I don't know how they could react. Unless it's clear, like they have a rainbow flag in their office or something like that. So this patient was specifically looking for symbols of LGBT support. And the patients in this study actually noticed safe spaces stickers that were around the organization where I was doing these interviews. that I hadn't even noticed. So they are really looking out for them. And these are a couple of examples of potential stickers. So the Safe Spaces stickers are available on the GLSEN website. And then there are also stickers available online that could be adhered to a badge that doctors use for identification or other healthcare providers use. Providers can make a really big difference in patient lives. So here I asked this provider, did you feel you could help the family support the adolescent? And the participant says, I kind of had to dial it back and say, hey, listen, let's think about new name as a small child. Do you remember what kinds of things he liked to do, and what kinds of things he liked to wear, and what he was acting like? And both grandparents were saying he never really acted like a girl. And I think that helped him to kind of understand that this is not a choice in a way. This is biologically who he feels he is, and he is. And he just has to make it look like it on the outside. So finally, this same provider, I asked, what is the most rewarding part of your work as a primary care provider at the end of the interview? And this participant says, it was definitely being able to make a difference in the life of my transgender patient in terms of his comfort with himself and coming out to his family. He and his grandparents are in a good place, and it was very meaningful to help support that. So caring for LGBT patients can be a very rewarding practice for primary care providers. All right, so this brings me to my final takeaways. So being LGBT is increasingly common, and we are all likely to work with LGBT people. LGBT individuals are affected by a number of health inequities, and how we shape the social environment affects LGBT health. And these are just a couple of additional examples of rainbow flags, symbols of support that are around BU and that can be shared in any office. So this is a door magnet and in my office, my BU mug with a pride flag in it. Are there any other questions? Okay, so I see a question. The news is covering the religious rights and business owners' decisions on who they serve. Do you think there's media coverage on startling figures on mental stress as well? If not, what can be done to get this important information into the mainstream news? You know, I think that the information on LGBT rights and religious refusal laws has been conflated as suggesting that that these are kind of two equivalent rights, and when you have two equivalent rights, how do you decide on one versus the other? I think what we saw here was that straight populations really were not harmed by policies that improved LGBT health. So they weren't harmed by like same-sex marriage policies. But conversely, we saw really big harms to LGBT populations in the presence of same-sex denial policies. So I think we really have evidence that LGBT populations are being disproportionately and severely harmed by policies that are so-called religious refusal policies. And so I think it's important to take that into account. I do agree that there has not been a lot of media coverage of this, and I think it's important for the media to be aware that there is evidence that, that these policies really have harmful effects on LGBT health. I think one other point that I'll highlight about that is a point that came up in the Masterpiece Cake Shop case. So there's this discussion of not providing a cake to a couple because they were a same-sex couple, which is what the case focused on. And then there was also this discussion of cake bakers who were different cake bakers who refused to provide cakes that had hateful messages on them. And what I'll say about that is that there are different externalities to refusing services to someone because of who they are, because they are a gay person who is part of a same-sex couple, versus denying a service to somebody because they wish to espouse a hateful message. That hateful message is not the essence of who they are, and it has a different effect to say, no, I'm not going to provide a cake that says this. I'll provide a different cake to you, though. But if you deny services to people because of who they are, then that has these really pernicious effects that we see play out in these studies. Are there any additional questions? All right, well, thank you so much for participating in this webinar. Please feel free to contact me if you do have additional questions come up. I've provided my email address and my Twitter handle there, and I appreciate the opportunity to do this webinar.